All right, so as mentioned, I'm Lawson McDonald, PGY6 fellow here in Florida, and I'm just going to be talking about TAVR leaks, kind of keeping in a theme from previously. So just to jump into our patient, we have a 73-year-old lady. She's severe symptomatic AS, already proven by echo. She has some comorbidities, but well managed. She's also noticed to have worsening symptoms. She's had some chest pain on exertion. She's had some dyspnea on exertion that's been worsening over the last several weeks to months. Hadn't had any prior cardiovascular surgery, no peripheral disease that we know of. She's got the typical murmur on exam of severe AS. Looking at her labs, overall, nothing remarkable. GFR is normal. NT-proBNP 326. Given all this into consideration from a TAVR perspective, she stratifies as low risk for TAVR. Looking at her EKG, nothing that we're particularly concerned about from a rhythm standpoint or from an interval standpoint, no conduction abnormalities. EF, again, demonstrates the severe AS with a normal ejection fraction. VTI is 88 with an estimated valve area of 0.64. Cath shows the same thing. She's got slightly elevated pressures. By pullback method, she's gradient of 67 with an AVA of 0.54. Planning CT gives us basically three options. We can do a Sapien 23, a Core Evolute 29, or a Navitor 27. Planning CT, you can see the leaflet calcification. You can see the annular calcification as well, and some calcium chunks in the STJ. Our angle's okay from an aortic root perspective. You want to be less than 48. She's 44. From a deployment perspective, that makes it approachable, and you can see that kind of extent and location of the calcium.
Would that make you lean towards one valve or the other? Okay, it's very calcified.
Yeah,
it's very calcified. Yeah,
very calcified, and so again, nothing from a peripheral perspective that we're concerned for. But for that reason, like Dr. Cohen is mentioning, we went with a Navitor valve because it's supposed to be a good valve for a hostile aorta, as they say, with kind of chunky calcium. Mainly the reason for that is because it has this NaviSeal cuff. It kind of self-expands in diastole and helps to create this kind of cardiac cycle-based seal for any kind of PVLs, and it can endothelialize over time, which gives you a more long-term solution for a PVL. So jumping into the TAVR, again, we see that we do have a little bit of AI at baseline, but that's our initial root shot. You can see we pre-dilate under rapid ventricular pacing with a 22Z med balloon. Here we're ready to deploy the valve, and we think we're in a good position. Valve is deployed, but if you see, we look a little bit constrained there just above the STJ and below the coronary. So we post-dilate with a 22 millimeter true balloon. It's a non-compliant balloon in attempting to try to better repose. So then we get a root shot to see how we did. We are still leaking at this point. We see quite a bit of leak from possibly around the valve, possibly intravalvular. We don't know at this point. Post-dilate again with a bigger true balloon, again non-compliant, this time 26 millimeters. And here's our post-shot there. We are once again still leaking. We still see pretty severe AI from a fluoroscopic perspective. So from this, I won't pause for input, but I will say we have to ask ourselves what do we do now? And the way to basically work through this is basically to say we have any degree of AR. Post-TAVR, we have to look at quantifying that, localizing it, and deciding what to do. So for us, at least from the perspective that we have, we're in this moderate to moderately severe range, and that puts us in having to decide, do we do a balloon post-dilation, do we do a valve-in-valve, do we close the leak with a plug in this case? At this point, we have to make the decision, do we do this now, do we do some intervention now, or do we wait? Or do we kind of give this lady a chance to maybe go forward and see if this leak closes over time with that natural valve closure technique? We can either stop, see how she does. We can do valve-in-valve, possibly, if we think this is intravalvular or transvalvular, and then or we could talk about actually closing this PVL, as you can see.
How bad is that leak for you?
Yeah, it is concerning enough to close it. It looks moderate to me.
Yeah. So.
Yeah, I mean, it does look significant, but I think the short axis view of the valve would give us more information in terms of how much of the circumference it involves. But in that just single plane view, it does look significant.
So if we're sitting here and thinking that, and we think, hey, we need to close this PVL or we need to do something, we have to consider the risks. And so the risks of that would be a wire deadlock through the struts. We pass a wire through these struts, and we're going to try to put a plug in there. That wire can get lodged in those struts. You can't pull back, and if that happens, we pull back, we dislodge the valve, and possibly embolize.
I've seen that when you can easily mobilize that valve and embolize it. It's a freshly deployed valve, so it's risky.
So that is a worry here. And like Dr. Placido was saying, we want to get a short axis, and as you can see, this is kind of the degree and extent of our PVL. So we post-dilate again with a commander balloon, in this case a volumetric balloon, trying to better oppose the valve. It does not prevent our leak. It does not fix our problem, and so we decide to move forward. This is our quantification of that actual vena contracta area. So in this case, we do wire through the strut. We go ahead and pass a Amplatzer device occluder across the valve. We exchange for the Amplatzer delivery system. You can see the wire across the valve here. Here by TEE, we're under TEE guidance. You can see our wire there in place, ready to deploy this Amplatzer device occluder. And in this case, now you can see us here on the left side. You can see the occluder going into place. On the right, you can see it actually in place and having been deployed. So we come out. Our final result here. You do still see a degree of AI, but much decreased from prior. And if you look at our TEE post deployment, you can see again a much decreased AI. You do still have some here. It's still that paravalvular same spot here on that kind of third, fourth beat, but you can see the device occluder in place. And if you look at this in a X-plane view, you can kind of see on that short axis cross section, it's much decreased. TT 1 month later, again rated at a low, much lower rate of aortic regurgitation symptomatically. She's doing much better. So finally, with this, when we're looking at this in the lab, TAVR goes in place. We still have some leak. We need to be diligent about figuring out by echo, by angiography, by hemodynamics, where this is, what is going on, and help that to determine what we're going to do. And those are our considerations for: do you post dilate the valve? Do you put a valve in place, or do you actually do a PVL closure like we did in this case?
Thank you.
Thank you very much.